Hello everyone, so my name's Botchey. I'm a consultant in sport and exercise medicine, meaning I've specialised in physical activity but also in musculoskeletal care. And here at the Lanzerhof, we've got many models of longevity, but one of the key pillars that Ray mentioned, and he's actually given most of my talk already, so I'm going to have to cut my talk a bit short. But one of the key pillars is about musculoskeletal health. And what I'm talking about today is that combination of looking at the root cause of musculoskeletal health and how we might be able to look at the cellular health to really regenerate us in general. So not just musculoskeletal health, but looking at cellular health and why we should do that. So, and I've called it the journey to longevity, and you'll soon find out why. So what is longevity? At its core, longevity is mainly about two things, and it's a buzzword. You know, in 2025, everyone is speaking about longevity. You turn around the corner, you see longevity. You get a cream, you see longevity. Everyone's talking about longevity. But really and truly, it's about two metrics, health span and lifespan. Health span being how well we live and lifespan being how long we live. And over time, most of us will have a depreciating health span. You know, we live up until a point and slowly we deteriorate. And that green arrow there, that graph, is where you get chronic diseases happening. And that can be neurodegenerative diseases, cardiovascular diseases, cancer. But the question is, can we push that barrier so that we're not actually getting chronic disease and we're living well later into our lives? So not just about living longer, but also living better for longer. And the single most powerful intervention for that, for both health span and lifespan, is exercise. Not just exercise, but movement in general, physical activity. So how do we measure this? Well, what is aging is the first question. I think people just see aging as growing older, but more and more it's being realized that it's a biological process that can be quantified by more than just the number. It's now being viewed as a disease. We can measure this. It's a biological process, and there are 12 hallmarks, and I've put all the 12 hallmarks here. I won't go through all of them, but they're all linked to aging in some way. But primarily, they're also linked to musculoskeletal health. And that's the kicker. All the hallmarks of aging are linked to musculoskeletal health. And we can go through them. We've got genomic instability, cellular senescence, where you're developing zombie cells, mitochondrial dysfunction. They all lead to things like osteoporosis and degeneration and poor muscle and tissue healing. They lead to insulin resistance. They lead to metabolic dysfunction. And all of these make our metabolic health worse. Every one of these hallmarks has a direct impact on the movement, mobility, and strength of how we produce ourselves. So if we ignore musculoskeletal health, we lose our ability to function. We lose our ability to live independently. And why is physical activity important? Well, I mean, this graph says it all. All-cause mortality dropped by 30%. If you exercise regularly, you're 30% less likely to die, 30% less likely to get dementia, 68% less likely to get hip fractures, type 2 diabetes by 40%, and nearly about 90% of people who have type 2 diabetes will develop dementia. So preventing that prevents dementia. You know, exercise is so important. But importantly, it prevents the very conditions that steal our independence. And if we look at this graph here, we've got multi-system level effects of exercise. We've got effects on brain function, on your liver, on your kidneys. They're all measurable in terms of what exercise can do. But also we've got these cellular hallmarks of aging. So actually, exercise isn't just about fixing you on the dramatic level in your muscles and your organs. It actually affects your cells as well. It has a positive effect on your cells. So research shows that it directly counteracts all those hallmarks of aging. So we actually have a cure to aging. We already have that. It's exercise on the cellular level, on the organ level, on the musculoskeletal level. So what is longevity? I can probably end my talk here, actually. Longevity is musculoskeletal health. That's what I wanted to say. You know, I've gone through there why longevity is important, what longevity is, how musculoskeletal health is important, and what aging actually is. And at the crux of it, musculoskeletal health is intrinsically linked to longevity. But in this nation we live in, musculoskeletal health is really poor. It's actually the most costly condition we have in the UK. And about 20 million people, the third largest area of the NHS spending, is on musculoskeletal disease. They not only contribute to chronic pain and immobility, they also lead to loss of productivity, a loss of mental health, increasing healthcare costs. I think 18.4% of adults have a self-reported MSK condition. That's a long-term condition, 18% of us. That disproportionately affect women as well, 20% compared to 15%. Specific conditions like osteoarthritis, there's 5 million people that have knee osteoarthritis in the UK, 3 million people that have hip osteoarthritis in the UK. It's a growing problem and it's not getting any better. And why is that? Well, I think there's a misunderstanding in crux of what longevity is. Despite us knowing musculoskeletal health is so intrinsically linked to longevity, we don't do anything about it. And modern medicine manages musculoskeletal disease really poorly. And I know myself and some of my colleagues are in here trying our best to manage musculoskeletal disease, but how we've learned about musculoskeletal disease up until now is probably not the right way. And this is the traditional approach. So what if I told you that we've been treating joint pain, arthritis, musculoskeletal disease all wrong for basically since the beginning of medicine? When we have some pain, we will mask it with some non-steroidal anti-inflammatory drugs. If the pain gets worse, you might come upstairs and I might give you a steroid injection into the joint. If the pain gets really bad and you can't mobilize on it, maybe you go to one of my colleagues and get a joint replacement. But what if I told you that we didn't have to do that? We could be more profound, look at the metabolic health of the person and actually adjust them earlier so they didn't get to the stage where they're needing surgery, joint replacement, steroid injections. So let me talk about some of those metrics. So non-steroidal anti-inflammatory drugs, things like ibuprofen, things like naproxen, things we take regularly, probably the most sold substance in the UK is ibuprofen. But did you know that they block healing? They actually block the very thing that your body's trying to fix. Prostaglandins, which are produced by COX-2, and COX-2 is that thing that produces prostaglandins, is required for tissue repair. We're blocking the one thing that actually gives us tissue repair. There's a significant increase in cardiovascular risk, more heart attacks, more strokes, by 50% with long-term use. They destroy the gut and the microbiome, and I could spend all day just talking about the microbiome and its importance and what we're learning from the microbiome, but what we know is if you destroy the microbiome, you destroy so many actual functions of your body. And I can't speak as well as some of my functional medicine colleagues or Dr. Shidwari on how important the gut microbiome is, but I can tell you that it's intrinsically linked to systemic inflammation, which affects musculoskeletal health. And steroid injections. Now, I must admit, this is the thing in my career I've done the most. I have injected more steroid injections than I could care to count. I put them into joints, I put them into muscle tissue. I've done several steroid injections. I've even injected my own knee, much to the detriment of my own knee, unfortunately. This is something that really works really well at reducing pain. It's fantastic at reducing pain. The problem is even one steroid injection changes that area forever. That area will never be the same again once it's had a steroid injection. And if you add multiple steroid injections into that, then you're getting into a worse and worse situation. It destroys cartilage. I've had a knee operation. I had to take some meniscus out that was flipped from a knee injury. And my surgical colleague who went in there said, mate, your knee is effed. He was like, how many steroid injections have you done? At that point, I'd done 4 or 5 steroid injections to try and resolve the pain. And it had disintegrated my cartilage completely. It is chondrotoxic. So if 5 is chondrotoxic, then 1 has a small measure of chondrotoxicity. That's chondrocytes being the stuff that makes cartilage. So it's a short-term relief, but actually you're worse off in the long term. You're weakening the tendons, and you're getting an increased chance of surgery and an increased chance of a poor outcome in surgery as well. And what about joint replacements? Well, it's a growing problem. There's 1.2 million total knee and hip replacements performed every year. One of my colleagues who I invited is not here, is the most busy knee surgeon in the country. He does over 1,000 knee replacements every year. This is something that is happening frequently and also in a younger and a younger population. So we are now doing joint replacements much younger. People in their 40s and 50s are getting joint replacements. But 30% of people with knee replacements are unhappy with them. 20% of people with hip replacements are unhappy with them. That is a staggering statistic. If I told you that you're going to have a knee surgery, but there's a 20% chance you'll be really unhappy with it. Oh, and by the way, this is not something you can reverse. This is a permanent. They've taken out your own bone and put a metal piece in. And the fact that they're happening younger and younger is a problem because they'll need replacement again. So we're doing revision surgeries much more frequently as well. So we're getting a growing problem with younger patients who are unhappy and needing redos later down the time. So what should we do? Well, come to my talk and listen to this. That's what we should do. Well, there's new methods of managing musculoskeletal health. And this looks not only at the physical health, but also the cellular structure as well. So we've got predictive biomarkers, blood tests and genetic tests that we can use. We've got advanced imaging now, really detailed MRI and ultrasound scanners. We've got biomechanical assessment. And we're lucky and blessed here at the Lanzerhof that we have probably the best biomechanical testing suite in the country. And then we've also got regenerative medicine. And this is the crux of the talk today. Can we actually manage things earlier with more regenerative therapies based on these information that we can get? So let's go through this. So we don't have to read all the slides, but it's here, and I will give the slides to anyone that wants them. But really, it's to go through the different facets of biomarkers that we can look at. We can look at muscle health. We can actually have a blood test that shows what muscle atrophy is going to look like, what your breakdown of muscle is going to look like. We can measure that. And we can intervene. We can do resistance training based on what your blood test shows. We can do leucine-rich diets, which is protein-rich diets, based on what your blood test shows. We can give enzymes like CoQ10 and NMN, which help that cellular structure to help you grow more muscle based on the blood test. Oxidative stress, 8-oxoguanine, it's a wonderful blood test because it really, really links to chronic tendinopathy. So we actually use this in athletes a lot. So in the sports clubs, every player will have an 8-oxoguanine test because we can then predict whether they're going to have chronic tendinopathy based on their loading regimen that they do. So that player will have a different metric to training because of that. We can prevent that happening because we know that blood test is positive. Homocysteine and nitrotyrosine, these are ones that not only predict rupture risk, but also predict inflammation. So we know how much medication we need to be giving them if we do, how much supplements we need to be giving them, maybe they need to be on an anti-inflammatory diet. These are all things that we can measure and do. Metabolic health as well, we look at HbA1c, predict diabetes, we can look at the omega-3 index, and everyone here should probably be on some level of omega-3, but actually that's measurable. We can look at your omega-3/6 ratio and tell you exactly how much omega-3 you need to be taking every day. We've got hormonal drivers like vitamin D, and I know we call vitamin D a vitamin, but it's actually a powerful hormone, one of the most powerful hormones that takes calcium and puts it in the right place. So with a low vitamin D, you're going to have a low bone strength. So that's another measurable statistic that we can use to measure muscle health. And then we've got the microbiome. LPS is really, really important, and zonulin as well, because zonulin links the leaky gut. So if you've got a leaky gut, you're going to have chronic inflammation. If you've got chronic inflammation, then you're going to have a worse off musculoskeletal system. These are all things, again, that are measurable, and we can treat this. We can give some glutamine, some probiotics that really, really help with this, and that's some of the stuff that we do here in the mixture of functional medicine, sports medicine, and regenerative medicine together. So I've just put that there because there was honestly, I could talk about this one slide forever, but instead I've just put all the data down so that people can see the references, and if you want the data later, you can take it away. But it really gives a specific mechanistic insight into the root cause of biomechanical disease. And by looking and pairing those targeted interventions, we can really work towards a reactive symptom management rather than waiting for the disease to take hold, real regeneration. And then we talk about advanced imaging. Again, we are blessed here. I honestly, every time I step into this building, I feel really lucky to work here because we have the capability to really prevent disease and add true regeneration. We've got a 3T MRI scanner, and we've got some great radiologists who can do some T2 mapping that actually maps cartilage health. So we're looking at the quality of cartilage from these really extensive, detailed MRI scanners. We can predict cartilage loss based on what we see in the molecular structure of the 3T MRI scanner. And then we can also do whole body scans. So not many people want to step on a scale sometimes, but how about stepping into an MRI scanner that shows you exactly what your body fat is? It shows you where your body fat is, and more importantly, how much inflammation that can relate to. So we can quantify that. A visceral adipose tissue of over 130 centimeters square leads to systemic inflammation and leads to osteoarthritis. T-score, so this is your bone density of less than 1, that can indicate a fracture risk as well. And then we add that in with high resolution ultrasound scanning, which we can do upstairs. We can really then push that needle and push that marker for cartilage depth, morphology, inflammatory markers, and really measure this. And imagine then combining that with the biomarkers as well. And the key takeaway from that is it pinpoints where the joint damage is. So I'm going to talk a bit about treatments now, in a second, but imagine that we know exactly where the cartilage defect is, so we can measure exactly where we put some of these treatments, and we can target them specifically before they become a problem, before they become significant osteoarthritis, before they're not able to run, before they're not able to play with their kids. This is something that we can really change. And now we get biomechanical assessment, and I know one of my colleagues, Edo, is going to get very excited about this post, mainly because his face is on some of the pictures. But downstairs as well, we have a 3D gait analysis. We can look at your knee adduction moment and predict medial knee osteoarthritis. We can look at your pelvic tilt and predict you having IT band syndrome. We can look at the force, but what's produced when you're walking, and predict patellofemoral pain just from the kinematics of the force that you have. We can also look at the angle that your ankle hits the ground and predict Achilles tendinopathy from that as well. And imagine adding that in to someone who's also got one of those biomarkers that hits tendinopathy as well. We're really then changing the needle and preventing that happening before it happens. And then we measure knee strength or joint strength through the Biodex machine, and we can really predict. So I think there's a really key marker here, and we use this in elite sport as well. So the hamstring to quad ratio of less than 0.6 is significant for ACL injuries, especially in women. So you can imagine this is the biggest problem people have. And there's someone here with an ACL injury. You know, this is something that happens on the ski slopes, happens when you're walking down the street, happens when you're playing football. You know, but having a hamstring quad ratio of less than 0.6 is predictive of that. So that's something we can correct immediately. We can get them back to where they're not at risk of that. We can look at, so now I put all of these on one slide because I haven't seen any of this equipment anywhere else. So the ones I mentioned before, lots of people have gait analysis, lots of people have a Biodex machine, but having a core strength measure that we only have here at the Lanzerhof. Having your ability to test your trunk strength, we only have here at the Lanzerhof. Your Minotaur for his cervical strength, the boxers want to come in for that, the rugby players want to come in for that. The concussions can be reduced by training on that, but we can also predict concussion on that as well. And then we've got the Dyer's postural analysis where we can predict how people's foot planting can affect their disease in the long term, like having a hip labral tear and things like that. So again, we're then looking again at a marker where we can really uncover the hidden movement problems that cause injury or joint wear, gait analysis that finds uneven forces and strength testing that reveals muscle imbalances. And we can check for all of these and combine them together. And then we talk about regenerative medicine. And I've got some of the equipment here that is regenerative in nature. We've got a PRP machine here, a shockwave machine here. We've got injectable therapies like arthrosomid, and I'll talk a bit about future therapies as well. So what is platelet-rich plasma? So that's the machine over there. If you come into the Lanzerhof for a platelet plasma injection, what will happen is one of the lovely nurses who's much better at me at taking the blood will take a volume of blood, they'll spin it in this machine, it will separate out, and the top yellow bit that's left over, the plasma, is full of growth factors. It's full of PDGF and TGF and VEGF. It's full of stuff that really goes towards healing. So instead of putting a steroid injection that damages you, we can actually put your own body's healing in a concentrated fashion, 3 to 8 times more concentrated than what you would normally do into the joint, into the tissue that's causing a problem. And this can synthesize and cause angiogenesis, which is the development of new blood vessels. It can bring anti-inflammatory cytokines in, which really reduces that inflammation. And it's been proven as well. So this is something that we know works. 60 to 70% pain reduction in knee osteoarthritis, a 80% return to sport at 12 weeks in a tennis elbow, something that's notoriously hard to treat. Tennis elbow through rehab and steroid injections is really, really, really easy to treat using PRP. And here at the Lanzerhof, we can also optimize your efficacy of the PRP. A lot of people will tell you PRP doesn't work, but have they optimized the person before they took the blood test? Have they given them nutrients? Have they made sure they're eating really well and at their healthiest point? Here we know that vitamin D levels, like I spoke about before, really affect your ability to produce PRP. Omega-3 levels, which again I've spoken about before, can really affect the amount of PRP that you can even improve and how it works. And we can give things like NAC and vitamin C and glutathione to really pump up that person, pump up their immune system and get them to a better level before you take the PRP. Talk about shockwave. Now it's a little bit painful. We'll turn it on so people can try afterwards. But what it does is essentially induces micro trauma, and that's what we want. We want the body to be producing its own healing factors. So it basically acts like a mini PRP system. It increases your nitric oxide, your VEGF. It increases your stem cell recruitment. It increases the blood vessels to the area, and it can really, really improve the really chronic conditions that are hard to treat. Plantar fasciitis, policeman's heel. It's terrible to treat normally through exercises and orthotics, but with shockwave we're getting really, really good results. Chronic tendinopathies in the shoulder, calcific tendinopathies when you've got a piece of calcium stuck in your shoulder. Again, shockwave can really, really be easy to treat in that manner. And then we talk about a few injections. So I know not everyone likes a needle, but I seem to be waving one around all the time because these regenerative methods can really change the game. Hyaluronic acid can re-lubricate the joint. Arthrosomid can go into the joint and bind to the tissue and really reduce that inflammatory cycle, that synovial pain cycle. And we've got up to, in fact, I put the wrong data there because arthrosomid now has up to 5 years of relief from knee pain, which is significant because some of these people would have had an operation at this point, a permanent operation, which I mentioned earlier, we've got a 20 to 30% chance of being dissatisfied for. But actually we can delay this and then add in some of the regenerative therapies as well. And this is why we're here today, because not just doing one of these things, but adding all of them together can really change the game. So we can optimize someone for their PRP while they're here. We can then do a combination of treatments where we add PRP and hyaluronic acid. We can even add arthrosomid into that if needs be. We can do shockwave as an adjunct to maximize the healing protocols as well. And then we can have a possible outcome of 70, 80% improvement instead of the 20, 30% we'd get from any individual metric. So we can combine all these treatments to give true regenerative therapies which are evidence-based. But what about the future? So I'll talk a little bit about some of this stuff. It's not available to us just yet, but I think it's really interesting for people to know about what's happening across the world. Peptides, everyone here has heard of a peptide. Insulin is a peptide, and Ozempic is a peptide. These are all things that are being used very frequently at the moment, but there are also healing peptides, so BPC 157 and TB 500. These are peptides that are short chain of amino acids that go in and stimulate some of that PRP type stuff I was talking before. They stimulate angiogenesis, they upregulate growth factors. We've got GHK copper peptide, which binds to the collagen and synthesizes collagen, so what you're then getting is better skin. So in fact, many of the creams that are being released for skincare have GHK copper peptide in, but imagine putting that in and around a joint, in and around a tendon. This is where we're really pushing that metric to improve someone by getting their own body to heal itself. I'll talk a bit about stem cells and exosomes. So stem cells are mesenchymal stem cells anyway. They're cells that can differentiate. They can go and become any cell. They're like the mother cell. So that we normally we can get them from ourselves, or in other countries you can get them from umbilical cords. But again, there's emerging evidence that these can be put into joints and put into tendons to regenerate the healing. And what they actually do, the stem cells, is they produce these things called exosomes. So exosomes are extracellular vesicles that go and send messages to areas to do stuff. And stem cells produce exosomes, but you can actually just give exosomes on their own, ready-made exosomes on their own. And the beauty of that is you're not getting the risk of the stem cells, you're getting a reduced risk. But the bad part about it is they burn out really quickly. They don't work as well as stem cells and they don't last as long. And then you've got AI. So the reason I mention AI is imagine protocolling all these things that I mentioned before, putting it into an AI system to actually predict injury, predict the treatment pattern, predict the protocol. These are things that are now happening. I know we all use ChatGPT, but imagine putting all that data and whacking it into ChatGPT to give really detailed outcomes of what we might be able to do. Obviously, they need to be bespoke and they need to be created and they need to have the right information inputted, but this is the future of what we might be looking at very soon. And when we add in the new biomarkers that are being created, so there's COMP, which shows rapid cartilage loss. So actually this is something genetically that you might have that means that you're more prone to arthritis. There's also MIR 140, which decreases synovial fluid, again making you more prone to arthritis. These are things that we can predict in people early on to prevent them having it, because actually imagine having hyaluronic acid more regularly because you know that your synovial fluid is going to break down more quickly. These are things that we can predict and give treatments for to prevent future disease. And then we spoke about gene therapy. I did invite a gene therapy specialist here. He hasn't come today, but the future is quite crazy in terms of what you might be able to do to manage disease in the long term, and or even prevent disease in the long term. Gene therapy delivers therapeutic genes into viral vectors. So they put them in viruses, they put them in your bloodstream, and they go and they actually edit your gene. So they can modulate things like Duchenne's muscular dystrophy. They can go in and modulate osteoarthritis. They can go in and modulate your ability to produce growth hormone and testosterone. These are things in the future that will actually change the game in terms of how we manage disease. It's an emerging science, but in 10, 15 years, we might be looking at a way to eradicate cancers from actually treating it through gene therapy, eradicate osteoarthritis early on through treating it through gene therapy. These things cost hundreds of thousands of pounds at the moment, but just like things used to cost hundreds of thousands of pounds now and are available in your palm, in the future, these are things that might be able to modulate musculoskeletal health and make us live longer. So finally, what is longevity? So I'm hoping that I've convinced you that musculoskeletal health is a cornerstone of longevity, and exercise is the most powerful anti-aging intervention. We're failing as musculoskeletal clinicians across the country, but we need to make a regenerative shift. We need to make a shift towards things that actually get our body to renew itself. And precision medicine, biomarker medicine, using regenerative therapies like PRP, shockwave, peptides, exosomes in the future. These are all things that could really change the game for us, and getting rid of the non-steroidal anti-inflammatory drugs that destroy the gut and the corticosteroids that destroy cartilage. We remove the things that harm, and we always say heal not harm and first do no harm, but actually that's not what we're practicing. We're practicing pain relief medicine instead of regenerative medicine, and we need to have a shift towards regenerative medicine. So again, I'm hoping I've convinced you that longevity is musculoskeletal health, and musculoskeletal health is longevity. Thanks for listening.
Sam, thank you so much. That was amazing. I've learned so much. That's great. So fast forward 5 years, what do you think we're going to be doing when someone comes in with an osteoarthritic knee? Do you think surgery's out?
I think surgery will be the complete last. It's not the last resort at the moment. I think what's happening is we know that it's available, and we know it's quick to do, and it's the easier option for the patient. So we're planning surgery earlier. But I think what's going to happen is actually those people won't come in with osteoarthritis in the future. In 10, 15 years, we'll have predicted the type of people that get osteoarthritis, and we'll have managed them early. So they'll have had training programs and nutrition supplementation, and hopefully exosomes and stem cells and gene therapy. They'll have had that before they get the disease. When they're at risk of having the disease, and this is something we don't do yet. We're very we in medicine in general. We always wait. And that's not what functional medicine is, I think, and that's what we do here. Functional medicine is about being proactive and looking at root causes of the disease, so that we can modulate them before they cause the definitive problem, which again, most of the time for most of us will be joint surgery or replacement, and that's what we want to avoid.
Music to my ears. Any questions from the audience?
I do have a question.
Sure.
Coming from a background of sport, coming from a background of training, I used to run 800 meters. I had an injury, so I tore my fascia, ruptured, and it took me out of my sport, something I loved to do, and not being able to run put me in a space of, I think the mental side, getting an injury is the worst, and if you're not aware of these things, if you're not doing the things to prevent these injuries, you're only fueling it to get worse. So in that journey of myself, I would say that the only treatment, when it came to doing treatment, it wasn't something that was 360. It looked at maybe one aspect, but then you fell apart on all the other different things. And I think not having that awareness definitely puts you in a position where you won't be getting back to doing the thing that you love. And I think working with a lot of young athletes and people that are wanting to push themselves, especially to an elite level, you need to make sure you're doing that. And it's one thing that I neglected in my own training. It pushed me to doing another sport, which is rowing now, and I'm pushing myself with that. But I think the awareness is definitely something I agree with. What is it that we need to do to change the conversation in thinking about these things? I think it's the communication side to it as well. And I would say that, I don't know, it makes me think about what channels are we having in terms of putting information forward, especially for the younger athletes. And like you said already, what do you think would be some of the best things? Is it interventions in schools? Is it interventions across the board of?
So I mean, I'm a bit biased about this, but I think what we probably have to do is meet people where they're at, and currently that's social media. So what we're not good at as clinicians or medicine in general is disseminating information, and there's always a suspicion of the hierarchy of medicine in general, but you know, we're damaging our society by not giving the correct information at the right time to the right people. And you're very right, this needs to be a younger generation of people that have this information so that they can do better for the long term. Not that it's too late for us, but you know, we need to look towards the future in terms of how we manage these diseases and prevent the burden of musculoskeletal disease that just gets worse and worse and worse every year. That's because we're becoming more inactive, we're becoming less cellular healthy. These are all things that we can edit by giving people the right information. So probably social media, but there's a wider scope where we need to have public health measures to really be able to edit this, but that's probably outside the scope of today's talk, but yeah.
The problem is the medical profession is so slow in catching on and taking on the new messages. And historically, that's been a good thing, because you don't want to jump on every bandwagon that comes along, and you want to be a bit of an oil tanker and turn where there's enough evidence mounting to support a certain intervention. But what's happening in the last 10, 15 years is that the rate of discovery of new things is sort of exponentially grown. And with AI coming along, we're going to be discovering new drugs every week. We're going to be discovering new treatments every month. And the medical profession is not really ready for that. And it's making it so much more difficult to be able to guide the population, the layman, as to what to take on board, because historically we had one good idea come along every 10 years, and we had plenty of time to decide if it was a good idea or not. Now there's 10 ideas a minute coming out. So it's a real thing that I sit there reflecting about, and how do you deal with it? Because if you jump on an idea too soon, you're accused of being a cowboy, or jumping on the latest fashion, or jumping on the bandwagon. But if you don't keep up with progress, you're doing your population, your public, a disservice. There's a very fine balance, and it's getting more and more difficult.
It comes back to the point that you said about it isn't about pain relief, but it's actually solving the problem. And sometimes I think the regression side of it, coming back down to doing things such as exercise and regressing the exercise to build back up again, that's one thing that I've seen, especially like my own dad had a knee injury, didn't want to take the knee replacement, but we pushed through doing those exercises, pushed through doing the diet, put all the things that could get you better. I think even just starting off in the beginning, it's a journey. It's a journey, 100% a journey, and you have to trust it in a sense. It seems a bit silly sometimes to go backwards, to go forwards, but sometimes you do need to take a step down and then build back up again.
Yeah, I think that's the basis of some of the medicine, especially that we practice here anyway, where we're looking at the root causes of stuff. We need to look at all the factors that might be associated and address the individual factors as we go along. So, we spoke about some of those today, but looking at the cellular health, looking at all the hallmarks and actually attacking each one individually is the way to make massive gains, by compounding all of those treatments all together. And you know, it's the same with the rehabilitation. When you're doing rehab, you do have to scale back and start from the beginning and mount up. And it's a difficult process for anyone who's injured or who wants to get better. But it's the same if you were trying to improve yourself when you go cycling or in the gym or run. You know, these are all things you can't just go and run a marathon tomorrow. You know, you need to scale up, and it's the same with treating musculoskeletal disease.
Saying you can look at the cartilage and see defects and things like that. But what age is the right?
So it's an interesting question, and I actually think the true answer will be personalised. So actually, based on some of these markers that we're finding, the genetic markers and the blood biomarkers, I'll be able to in the future be able to say, actually, at 25 years old, I need to be doing an MRI to find out what's going on in your joints because your risk factor is higher here. Or actually for you at 54 years old, I need to be looking. So it's going to be personalized based on some of these metrics we have now. Now all we have is pain, discomfort, we have malfunction, but by that point it's too late. So what we've then done is we've waited until we need to influence a treatment, and in the future what's likely to happen is we'll be able to predict having a treatment, and it will be individualized. There will be no marker where a 24-year-old should have this and a 28-year-old will have that. It will be individualized to the person, protocolized towards that personalized metric based on some of these tests.
So now, how do you consider when it should be done?
So now it's just discomfort, pain. But what we're lucky to have here is the beautiful biomechanics testing service. So what we can do is for any person or they can be tested in terms of their joint kinematics, and we can predict injury from there, and then we can plan treatment. And some of the knee regeneration protocols we've got going now aren't based on pain. They're based on some of the findings we find in the kinematic center, because what we can then do is predict, actually, you've got a significant risk of osteoarthritis and your knee is at a severe valgus, and we do a cartilage mapping and we see that the reduction is great, and actually that person is having PRP much earlier than they would do had they just presented with pain.
Sam, that's good. So just thinking about your career, I'm coming toward the end of my career, and what you've spoken about today, I hope you're very successful in your career, what you're aspiring to do. Where do you think the fight is going to be? Because orthopedic surgeons like people to have bad joints. They like that because they make money out of it. Rheumatologists like people to have inflammation because it gives them a purpose for their lives, and they maybe don't want you to be quite so successful in the long run. Drug companies, they want people to be ill. They want people to be diabetic because that's the way that they can sell their drugs. They like people to be overweight and obese and ill because that gives them a reason to produce more drugs. I just wonder where you feel like this fascinating area of medicine is going to go, and the degree of opposition that you will naturally get from those that will feel, well, I could be put out of business here.
I think it's from all those facets that you spoke about. So, I work with some fantastic orthopedic surgical colleagues that don't believe that. I have to say that because they're standing here. But, I think that you're right in the grand scheme of things. Most orthopedic surgeons want to operate. That's what they're good at. That's why they exist. Much like we exist to assess musculoskeletal health or gastroenterological health. And there is metrics where people need surgery. At the end of the day, there is metrics where people need stuff to happen. But what's happening now is that we've gone so far past the pale where everyone is just doing it because that's what's done, rather than measuring all these things that we spoke about. I think the fight's going to happen because when we start discovering some of this new information, people are going to be put out of business, people are going to be upset about their normal standard of practice, and they're not going to be willing to change. And that willingness to change is something we've all had to learn in medicine as we go along. How we manage knee pain today shouldn't be how we manage knee pain in 2 or 3 years. We should have new information, we should have new biomarkers, new tests, we need to move along with those times. And anyone who isn't doing that, who is managing things the old way, is unfortunately either going to be left behind or going to be fighting that old fight. And I think that's where the main metric is going to come from. I don't think it's going to come from the pharmacological companies, actually, because I think what's going to happen is the new treatments that we have, they're going to monetize those every time that they come. Every new step is going to be attempted to be monetized by someone. But I think as clinicians here, we need to be able to be the standard bearers for regenerative health and making sure that we're trying to do the most with the least, if possible.
Knowledge is power. You're not going to be able to reverse that wave of information that is flooding us with social media. These companies, I agree with everything you said, and it's so true, but I think they're going to find that the public's level of understanding is going to grow exponentially. And when these things that Sam's talking about today, which might sound very futuristic, in a few years' time, they'll be standard. They'll be able to read about this on your phone, and that's going to empower the population. And it's a gradual process, but it's growing exponentially.
And it's already happening. You know, we unfortunately we're here in the UK, but there's a wide world around us, and some of this stuff that I mentioned is, you know, future therapies is not future in places that, you know, where they're already using them. So, you know, we are being held back a bit by regulations, and you know, regulations are very important because they keep us safe, but at the same time they restrict the new production of progress in general. So yeah, you know, and I think hopefully that changes as time goes along, and unfortunately we often have to bring a bad apple into the market to be able to change some of the stuff, but actually we need to be looking towards those new therapies so that when they come, we're ready to use them. We know what they are, we understand them, and that's what a lot of this talk is about.
I think it will be fine and you'll be okay, because look, at the end of the day, those patients who don't want to think in that way will go to those doctors who will still send to those consultants who will also not think in that way. And people like me and many of us, instead of referring straight to someone for a joint replacement, are going to be turning to them. So I think there will be a nice even balance, and all should stay calm and there'll be no.
I hope so. You said which one, sorry?
Yeah, so you said some of the future.
Yeah, so peptide therapy, for instance, is widely used across America and North America. Exosomes and stem cells are used in Europe and in America, widely used in Eastern Europe, for instance. There's lots of good studies on them, but they're not replicable very easily, and we can't replicate the outcomes very easily. So because of that you can't license them in the UK, but you know, there's evidence that stem cells work very well. There's evidence that exosomes work very well. There's evidence that peptides work exceptionally well, but these are not things that you can market very easily or have big studies on. So you know, pharmacological substance is something that a pharma company can create and make and put their name on and say this, but you can't do the same with a stem cell. You can't do the same with a peptide because it's a naturally produced substance, so you can't monetize that. It's cheap. It's too cheap for them to do a £1 million study on, and most of the time what we need is randomized controlled trials with double-blinded. These are huge studies with meta-analyses, and you know, they cost so much money to make, and they're often funded by pharma companies.